All right, we might kick off, I think. And thank you all so much. It's clear this is a really big issue that brings so many people out on at this hour. My name's Kim Sykes, and I'm here representing what is a consortia of alcohol and other drug service providers that came together in response to a request from Council to look at how we might deal with, say, a really concerning community issue. Tonight, our principal purpose is, as I said, in responding to that which we know to be a real community need. We're not here to sensationalise the issue of alcohol or drug use. We're here to give you good, solid information about both about the drugs and also about the services that are available. And we're also here to listen to you. It is our belief as a group that we are very likely to see some gaps when we're answering your questions, where we're going to find that the services we all offer may well be of really high quality, but sometimes the need doesn't fit neatly into that stream. So we're looking forward to learning about, we think it'll be painful, but we are looking forward to hearing about that as well, because it's a commitment that we make to you and indeed through Council that we're looking to some of the learnings tonight, helping to shape how we plan as we go forward. So now you get to hear, it's my great pleasure to introduce Peter Wern, who is the Director of Services for YSAS. And Peter is going to provide us with a lot of really terrific information in a really easy to understand way. Thanks, Peter.
I'm a tragically devoted St Kilda supporter. Okay, so I was listening to the ongoing saga of what's going on with my club and on SEN. And at the end of the show with the Ox and other people as I was coming up, they had a session on boutique beer and alcohol, and they were talking about patterns of drinking, and they started talking about brown liquor and bourbon and rum and things like that. And I nearly drove off the side of the road because they were talking about their drinking as fun and talking about, well, you start off with 8 or 9 crownies, and then you move into the happy space of hitting the bourbons, and you have another half a dozen bourbons. And then people were ringing up and saying, I find the next morning that the thing that's really magic is a UDL vodka, lime and soda. You have a couple of those in the morning and then you can start all over again. And the thing that struck me about this conversation was just no one was talking about alcohol as a problem. It was all associated with good times and fun. And so the point that I'm trying to make is the culture that we live in this country associates alcohol and drug consumption. We've got members of the police force here today that'll tell you about the troubles that alcohol abuse and misuse causes in their world and the community generally. And if we had people here from family violence services, they'd be telling you about the strong link between alcohol misuse and family violence. And I dare say in your experience and your friendship circles and maybe in your own life, there are people here who've experienced that connection too. So the point I'm trying to say is that Australia has a very, very confused relationship with drugs, and especially drugs like alcohol. But we'll get into that a bit later. So can we have the first slide? Okay. So what we're trying to do here is we're going to talk about factors that influence drug use. This is going to take, I've got 8 slides, I think, so don't be put out by the PowerPoint. So where we start with, the drugs and alcohol don't have a mind of their own. Drug and alcohol problems are people problems. People are at the centre of drug and alcohol problems. And lots of things impact on how those problems can either be dealt with and affected in a positive way or become really difficult. So some of the reasons that people get into trouble with drug and alcohol are limited by these factors here. And it's sorry about this, I'm going to have to stand here because I can't read it up there. So we're talking about macro environmental factors so that we know when we have communities that are really affected by economic downturn, high unemployment, things like that, we see drug and alcohol problems increase. Like we see mental health issues like depression and anxiety increase. So macro environmental issues really affect drug and alcohol problems. Then we have local environmental factors. So that might be a national thing or a regional thing. Then we have particular things that go on within communities, and they can have impacts on the problems of drug and alcohol within that community. So there might be a tragedy. There might be something that affects a community that's really terrible. So for instance, the bushfires in some communities. We have seen a rise in drug and alcohol problem issues in those communities that were severely affected by bushfires. And we've had to put in lots of resources as a state to ameliorate those problems and to provide support to people experiencing those problems. Then we have family factors, family violence, separation, an unfortunate death in the family, loss of a job, all sorts of issues that might go on with families. That can see rise to problems with drug and alcohol. And then we have individual factors, things like undiagnosed mental health issues, maybe chronic issues that haven't been diagnosed like depression or anxiety, personal relationship breakdown. We've all known people that have gone through a marriage breakup and we found that they've been drinking too much or suddenly taking too many drugs to compensate for the sadness and feeling of loss. Even the death of a parent or a child or a partner can lead to those sorts of issues. And all these can affect drug use behaviour, and they can all affect them simultaneously or at different times. And you can have the perfect storm where you can be in a situation where all these things are in play at the same time and people don't know how to cope. And we'll talk about why drug and alcohol a little bit later. Drugs and alcohol are often seen as convenient answers to very complex short-term problems for individuals. Let's move on, mate. So really, when you think about drugs, you can divide drugs up into three categories: stimulants, depressants, and hallucinogenic drugs. Can anyone tell me what a stimulant drug is? There's been a lot of publicity about this stimulant drug lately. Ice. Ice is a stimulant drug. What ice does in your system is it stimulates your central nervous system. It's a go-fast drug. Kerry and I were talking about today that we've seen a lot of young people who have been traditionally using cannabis starting to use ice, and that one of the things they report to us is that it makes them feel better. Because part of what a stimulant does, it generates within their own brain feelings of happiness and excitement. Now, this is not long-term, it doesn't last forever, but we're talking about the short-term effects of the drug. A depressant drug, can anyone tell me what a depressant drug is? Name one. Alcohol? What alcohol does? Alcohol's an interesting drug because it does report to have some sort of semi-happy euphoric effect we're all experienced with alcohol. Most of us will be in this audience. People drink because it can make them feel better. But what it really does in your central nervous system is it quiets it down. It slows your central nervous system down. It's a go-slow drug. An hallucinogen, someone who isn't from the drug and alcohol sector. Can anyone think of a hallucinogenic drug? LSD. So there are some people that were born in that relived the 60s. So LSD was extremely popular in the 60s. And I might say there are communities of people within our country that still use LSD quite regularly. It hasn't gone away, it is there, but not used by lots and lots of people. It's used by particular communities of interest of people. Now, these drugs are interesting because they're not so much stimulants or depressants, but they reorder the way you perceive reality. So sound can smell. You got that? So you experience sound as a smell. You don't experience it as a smell. Colours can make a noise. It reorders the way your brain interprets all the normal information you get. It restructures the way your brain understands it. Now, this can be an extremely frightening experience for people. Some people report it as being a very pleasurable experience, but it can be a very dangerous experience as well. Can we go to the next one? So we talked before about depressants. These are the lists of drugs that are commonly around that are depressant drugs. So we've got alcohol up there. We've got the word benzodiazepine. The S is meant to be at the end of the benzodiazepine. That's the family of drugs that you would know as Valium or Xanax or what's another one? Seropax, Rohypnol. These drugs are drugs that slow your central nervous system. They're used in a therapeutic way. Doctors prescribe them, and they're used to help people with all sorts of issues, including anxiety and including difficulties in getting to sleep. In fact, I'm a terrible flyer. I get great anxiety when I fly because I have control issues. I wouldn't have anxiety if I was piloting the plane, but because they won't let me pilot the plane because I have no pilot's licence, I get very worried about people flying the plane when I'm not. So when I first started flying or travelling by plane, I used to be prescribed by my local GP some benzodiazepine because it calmed me down. It took the edge off my anxiety. Then we've got cannabis. Then we've got a drug called GHB, which you will see some of in your communities in terms of the nightclub scene. These are all drugs that are central nervous system depressants. And interestingly, glue and paint and petrol also are central nervous system depressants. Where people get into trouble with these drugs is that when you slow your central nervous system down too much, you can die. So you hear about heroin overdoses, and of course we haven't talked about opiates, but heroin, opium, all those sorts of drugs, in that family of opiates, they are central nervous system depressants. And what they effectively do is at an overdose level, you actually physically forget to breathe. You forget to breathe. Here's an interesting thing to do. You try holding your breath for how long? How long can anyone hold their breath for? The champion breath holder in the audience. How long? Minute, 2 minutes? Maybe? You have drugs in your body that your body produces that forces you to breathe. It forces you to breathe. That's why when you drown, your lungs are full of water, because eventually when you're underwater, you breathe. Your body forces you to breathe because there's a chemical in your blood that measures the level of CO2 in your blood or oxygen in your blood and triggers your diaphragm. It also means you can sleep and breathe at the same time. You don't have to be awake to remember to breathe. What opiates do at high levels, where the overdose comes in, is it overrides that system and you literally forget to breathe. It overrides it, you just don't breathe. Let's move on. And of course, the stimulants, we've talked about ice, which is methamphetamine, and amphetamine, which is in ice is in the amphetamine family. Cocaine, which we don't see a huge amount of in this country. Ecstasy, which is an interesting drug because it's sort of a semi-hallucinogenic drug, but it's also in the stimulant family. Nicotine, anyone here smoke cigarettes? Ex-smokers? Have to be about half the room that'd be ex-smokers. One of the things that tobacco, apart from all the social factors around drug use, like smoking that makes it attractive, nicotine is a very effective drug in terms of stimulating you and helping you to concentrate. It's just that the delivery system of that nicotine into your system is incredibly dangerous. Burning tobacco and inhaling it is not good for you, right? But there are benefits to it. Kerry's laughing at me. And caffeine. That's why caffeine is banned from the Olympics and from all professional sport, because caffeine is a stimulant at high doses. I think there was an Australian pentathlete that was banned in an Olympics about 20 years ago because he would have had to have drunk something like 250 cups of coffee in one day. His caffeine levels were so high. So caffeine, pure caffeine in tablet form, is a very powerful stimulant. Let's move on. And the hallucinogens, we've talked about LSD, ketamine. Does anyone know what ketamine is? It's a vet's drug. Can anyone explain to me what ketamine does? So in drug culture, you go down the K-hole, and it's a weird drug because you virtually go into a trance-like state. And I've seen people on ketamine lying on a dance floor, and I'm thinking, why would you take a drug at a nightclub where you end up just lying on a dance floor going down the K-hole? I don't see the attraction of it. But it is reported to have hallucinogenic factors in it or influences. And there's other drugs like Datura is the trumpet lily, which is in the right-hand corner, and also magic mushrooms. And so at a certain time of the year around Victoria in certain areas, you'll see people out looking for magic mushrooms, and they have a very powerful hallucinogenic effect. So they're the three categories. So when we talk about any sorts of drugs, they're always in those three categories, except for one set of drugs which we haven't talked about, and they're steroidal drugs. and I didn't bother to talk about that today. Let's go. So, patterns of drug use that we see, and this is really important to understand, is that not all drug use is dependent drug use, and we'll talk about that later. So a lot of people start off experimenting with drugs. That's typical adolescent stuff. They might get into recreational use, so we use the term party drugs for some families of drugs because they're not used every day. They're just used purposely around, say, one night a week or 2 nights a week. Then it's situational drugs, and that might be... How I would talk about situational would be in a functional way. So interstate truck drivers using stimulants to drive. They're not looking to have a good time, they're looking to make an income. The laws are really tough about single drivers interstate. They take a drug to keep themselves awake. They might even take caffeine tablets to do that. Then we have intensive drug use and dependent drug use. Just click on the thing because something else will come up. So people move both ways along that continuum. So people can at some stages be experimental in their drug use or recreational in their drug use, end up in trouble and become dependent and move back. And the other thing to say about this is people often use more than one drug at a time. So it's very, very common, especially for people under the age of 35 in their drug use, that they will use more than one drug over a period of time. Keep on going. So one stage does not necessarily need to the next. I don't think we don't need to go to that. But regular drug use does not necessarily lead to problems. And we see that with alcohol, right? So you can be a regular alcohol drinker and never become an alcoholic. Now that doesn't mean to say you won't develop problems because of your drinking, physical problems, but you won't become alcohol dependent. So one of the things you need to know is what are the drugs that you can die from when you are dependent if you stop taking them and go into withdrawal unless you are medically assisted. Does anyone know the 2 drugs out of all those lists? So if I'm using a drug and I'm an addict and I stop taking that drug and I don't seek medical, so I go cold turkey, what are the 2 drugs that we've gone through that you could die from? Alcohol, not heroin. Alcohol and benzodiazepines. So if you know people that are alcoholic, the worst thing you can tell them is to just stop drinking without seeking medical assistance. They need to be medically supervised if they stop drinking alcohol because the withdrawal can kill them. Yeah? Let's keep on going. Now, these are figures from household surveys from 1993 to 2010. And what this says is they rang up over 30,000 people throughout Australia in households. So these aren't people that necessarily have drug problems. These are just household surveys that are done by the Australian Institute of Family Studies. And they ask a series of questions around all sorts of things. Drugs are covered. And what did they find? In 1993, they found that 29% of people that answered the survey smoked tobacco. In 2010, it's predictable, isn't it? It's now only about 17%. So in that period of time, that 17-year period, we've seen a massive reduction in tobacco smoking within Australia. We look at alcohol, 78% of people that answered the survey were drinking, not every day, not dependently, but were drinking regularly, so maybe once a week or once a month, right? And now we've got 81%. So there's very little change there, only a 2% differential in 17 years. What you notice, and the point of why I put this up, is that when you look at all the other drug types, which basically go into the illicit types, they don't add up all together to alcohol. The drug that we use mainly in this country is alcohol. Now that doesn't mean to say that the harms caused by those illicit drugs to communities aren't great. The one thing I'll point out here is the methamphetamine. So in the methamphetamine figures, which is ice, right? You probably can't read it. It went from 2% to I think 2.1%. So a 0.1% increase in methamphetamine use in 17 years as recorded by the household survey. I will say that that will have gone up dramatically in the last 3 years. The next household survey will see that might be 4%. It might be 5%. But one of the things you can become seduced by is thinking that I used to train the police years ago. And the first thing I used to say to the police was, how many young people do you think use heroin? And these were people training to be sergeants. And they would say to me things like, 30% of young people have tried heroin, or 40%. And I'm saying, how many of you guys, and it was mainly guys in those days, are fathers? And most of them will put up their hand because these are more senior men. So you're telling me that your children, out of all your kids, you reckon about 30 to 40% of your kids have tried heroin? Oh no, these are other people's kids, right? But because police work with that population of people intensely, they get distorted, as I would, in thinking that this is much more prevalent. But the truth is, the prevalence of these drugs in the community is not that great. But the impact of these drugs in the community on individuals and families and societies is great. It's disproportionate. Yeah? Let's move on. So, these figures are about people in treatment. Now, these are figures from my own organisation. We've just recently conducted a survey of every young person in drug and alcohol treatment services across Victoria at a point in time. So on one particular day, 1,000 young people's information that were in treatment services was analysed. And what did we find? That when young people were talking about their drug use that were in treatment, remember, this isn't all young people, this is young people that have been identified as having a drug and alcohol problem, you see the difference in the way the figures match to the household surveys. Yeah? And what you see here, and I'll draw this to your attention, if you look at methamphetamine, remember it was 2% in the household surveys, which the young people in treatment, here it's 35% in the last 4 weeks talked about using ice, and almost daily use was around 13-14%. So with a population of people that have trouble with drugs, the figures and the graphs change. Okay? Next one. And the primary drug of concern, and this is when you ask people when they come into treatment, what is the drug you... So I might drink a beer on the weekend, I might occasionally smoke a joint, but the drug I'm really worried about is ice. I name the drug that I'm most concerned, even though I'm using 3 or 4 different drugs, which is the drug you are most worried about and you want help with, this is this question answered. And so what we see is cannabis is still, across the state, the drug that young people are saying. Now these figures are within the last 2 months. They are very contemporary. But methamphetamine, and I can tell you this for a fact, methamphetamine 18 months ago was 7%. It is now 25% and going up, right? So in 18 months, we've seen nearly a 400% increase in young people telling us that that's the drug they're worried about when they seek help for drug and alcohol issues. And of course, alcohol is there. But you see, the drugs like heroin and those that have traditionally got most of the attention are actually rather small in comparison in terms of people seeking help for drug and alcohol issues. Now, if you'd gone back 17 years, not 17 years, 14 years, heroin would have been off the charts. When we set up our drug treatment service in the late 1990s, 99% of all the young people that we dealt with came to us because of heroin dependency. 99% across Victoria. Now that's changed. Let's go. And this is where we're going to finish. When we think about drug use, we've got to think about these 3 words. And I know it might sound a bit simple, but they're really important words. When you're doing drug and alcohol work, the first thing you've got to work out when you're talking to a person about their drug use is what is the purpose of their drug use? What are they trying to achieve by taking drugs? Is there a history of anxiety? Is there a mental health issue? Is there a deep-seated what is it? What drives you to use that drug? Because most people don't go there with drugs and develop drug problems. It is still, thankfully, a relatively small percentage of our population. What meaning do they attach to the drug use? And this is almost a philosophical question. What does it mean to them? What does it make them feel like? What is the existential reality of drug taking for them? It's almost a spiritual question. And the last one is what function? What does it help them achieve? So if I was to walk up to that wall and start banging my head against it, and you came and stopped me, but every time you stopped me, I went back and did it, you'd say, I can't understand why you're banging your head against that wall. I don't want to do that, it hurts. But I keep on going and doing it. The first question you have to ask, what function is me banging my head against that wall? Because I keep on doing it. Now, I'm not an idiot. There must be a reason. And so here's the point I'll leave you with. Drug and alcohol use, there is a reason behind it. It is not because of stupidity. It is not because the person is bad. It is not because the person is somehow subhuman. It is because there is a reason. Now, they mightn't even understand the reason themselves. But our job is to help them discover what that reason is. Because through that discovery becomes change and hope and recovery. Okay? So I think I'll leave it at that. Thank you. Cheers.
Thank you, Peter. I know lots of information and hopefully lots of questions already answered, but for those of you that have got questions, remember if you can just note them and we'll try to make sure there's time at the end to deal with those. Now, I do think, and I think the people on the panel have probably got the worst gig here, because to just have to sit up in front of you all and wait until they're called, and we haven't introduced them, and mainly as a time-saving thing and figuring that you might not remember then when they came around to talk about their bit. So just to let you know, you will get to know who they all are and where they're all from, and we are going to do that by having a couple of individual sessions first, and then we'll move through the service providers highlighting what their services are about, and then a scenario which we hope will make things more alive. So to kick things off, and modelling the new police uniform is Acting Superintendent Brad Dixon, who's going to give us the policing perspective. Thanks, Brad.
Thanks, everyone. Look, I'm not far less accomplished than Peter at this sort of thing, so you'll have to bear with me. I had some PowerPoints, but I'm opting not to use them. I thought I want to try and keep it a bit informal. So I want to try and give you a little bit of perspective today about the policing role in alcohol and other drugs. And Peter did a great lead-in, although we haven't spoken about our presentations. Some of the stuff he was talking about was really relevant to what I want to talk about. And first, I perhaps should set the scene. And 27 years operational experience for myself, and it started back in Melbourne. We had the main drug of choice back then was the heroin, which was we saw a lot of around the South Melbourne, St Kilda areas. But that has been on the decline ever since the 90s. So, we've come through a range of illegal drugs, and I describe drugs as either legal or illegal. We've seen a range of drugs across the decades leading up to the very high-profile media around ice at the moment, and also, some synthetic drugs and prescription drugs. But the drug I most think is a problem to police is alcohol, and that's by far, it's the main driver of crime in the area, and it's not just here, it'll be across the state. It is our main problem, and I will stress that a couple of times during my presentation. I'll use some anecdotal evidence mostly through this presentation, but I'll also refer to some facts and figures. And that's purely because a lot of the facts and figures that are out there are a few years old, so I want to try and put a bit of perspective around what we as police actually see out on the street. So I've talked about the range of drugs, from heroin we've come through speed and ecstasy, and a lot of cannabis has stayed steady through it all that time, and we're moving into ice and synthetic drugs, but we include prescription drugs in that. We see a lot of problems around prescription drugs and dependence on those, and it causes a bit of crime. We also see some volatile substances, and when I refer to, and Peter touched on it before, about glue sniffing, paint sniffing, petrol sniffing, that sort of stuff. So I will touch on that again later on about what the police response to that is. But once again, I'll just mention that alcohol is our main problem out in the community, and that's daylight's a big second. Just some of the alcohol facts about why it's probably such a problem. 20,000 liquor licences in Victoria, over 20,000 liquor licences currently. We process 15,000 drunks annually as police. And when I get into some of the things we do around alcohol enforcement soon, I reckon all of those 15,000 drunks at some stage would have been told to go home prior to getting locked up. So I'll probably give you a little bit of a hint leading into my next slide. 40% of all family violence incidents, alcohol is involved. 65% of all police attendances, alcohol is involved. 60% of all 18 to 24-year-olds binge drink. And probably the most recent fact we've got, and we get it from our data, our policing data, when we interview people when they are arrested for alcohol type offences, 60 to 70% of all people who get arrested while affected by alcohol or drugs are using their drug at home. So it's a bit of a myth that people are out in the streets taking drugs and drinking alcohol. They're, you know, in laneways, in pubs and clubs and all that sort of stuff. Most of the alcohol abuse we see is from people drinking at home, which makes it very difficult to tackle. And that's why it's not a policing issue, it's a community issue, and it's a health issue. It's, and that's the other major point I wanted to get across tonight. I've talked about the volatile substances before, and just our policing response to that. Everyone knows, you know, it's pretty high profile in the community that police get out there and we arrest people for, you know, possessing drugs and things like that, and we process them and put them before the courts. But I wanted to talk about a few of the other things we do and why we do that. And the main thing is we want to help people. And that's the driver behind that, those volatile substances. There are people out there who sniff paint, sniff petrol, sniff glue, those sort of things. It is a problem. And our response to that is that we don't charge people for that. It's not an offence, so we won't charge people for that. Our response to that is we will take the item off and we'll dispose of it and we'll get those people help. So I wanted to make it clear, and it's similar to when we go to overdoses. When people overdose on drugs, the AMBOs will often call us to attend with them because it's a dangerous situation for them and they're not equipped to respond to violent people. So we will often go to overdoses as well. When we go to overdoses for someone who has used a drug, we will not prosecute that person. We found that in the 80s when we were doing that and we were prosecuting people for using a drug of dependence and they overdosed on it, their friends who were with them weren't calling an ambulance because the coppers would rock up and charge them. Okay, so once again, it's a health issue. We won't prosecute people. If the only offence they've done is taken a drug and they overdose, we won't prosecute people. Okay, I just want to get those sort of couple of messages out. They're not well known in the community, so you know, if you see people who have overdosed or you see people who have problems with the chroming offences, please get them help. If we turn up, we will not charge people. It's a very important message to get out. So some of the alcohol outcomes with police, yeah, we do you know, charge people with alcohol-related offences, but we would much rather not do that. So the main sort of message I wanted to get out in the community is if you're asked to go home, go home. And it's a really important message. We get people arguing with us at 2 o'clock in the morning in Pall Mall, Bendigo about, you know, whether they're drunk or not. Please, we've got powers to move people on. Please just, we want to get that message out to go home. We don't want to lock people up for being drunk. It's the last thing we want to do, especially with the crowded jails we have at the moment in police stations. And it's, we just want people to go home or with friends or relatives. We can issue banning notices, penalty notices, $577 for a drunk, if you're drunk, found drunk in a public place at the moment, really expensive. So once again, if you're asked to go home, go home. $722 if you're drunk and disorderly, you know, so they're very serious, serious fines. We don't like issuing them out because we know people, it's hard enough to get by in this day and age without getting a fine like that to go home on a Saturday night or a Friday night. We also deal with charges, obviously, and there are certain methods we can put people before the courts, and that's with, you know, through summons or charge and bail. We also divert people. We can divert them through the courts, and I'm sure that'll be spoken about in the next presentation by Legal Aid. So the purpose of those diversions through courts is to get people help. Okay, so you'll see a common recurring theme with what we do is we want to get people help. And people who are affected by alcohol and drugs that we process, we also refer them onto support programs, but they have to agree. They have to agree to that for us referring them. So that's the only sticking point with that. Some of the drug outcomes, once again, I've spoken about the overdosing, how we take no action. We have cannabis cautioning programs, we have drug diversion programs. There are court diversions once again, there's a credit bail system through the courts. There's lots of diversion programs there through the courts and through our processes where we can get people help. And it's all about getting people help so they don't reoffend. There's some of the drug outcomes, of course, not the alcohol ones. And once again, the charges and referral, really important messages. We try and refer everyone we get to process for drugs and alcohol to other support services to try and help them. And that's the main cause of what we do. And the last issue I want to touch on, as I said, mine's only a short presentation. The last issue I want to touch on is mental health issues. And I know it's only vaguely linked to this, but there are a lot of people we come into are at the pointy end of their crisis, we get called. Often affected by drugs and alcohol, and they also present with a mental health or a mental illness. We're not doctors, we're not trained as doctors or anything like that. We have a power under the Mental Health Act though, if someone is appearing to us to be mentally ill, to arrest that person and take them to a health practitioner. So that is what we will do. If you have committed, or if someone's committed an offence, and while they're mentally ill, we will still process them for that offence, but at a later time, and it'll be the mental illness will be taken into account in sentencing. Okay, so it's not as if people get away without being held to account for their actions. But under that Mental Health Act, our prime responsibility is when we see people in serious crisis like that, and it's usually around attempted suicide and things like that. I don't want to go into that tonight. That's a whole other conversation for the community we need to get out there. It's usually around attempted suicide, and that we will front them before a doctor or a psych nurse or someone like that. Okay, so really important messages we need to get out is some of the other things we do, rather than just locking people up and seizing drugs and getting a picture in the paper with some cannabis plants and that sort of stuff. A lot of what we do around drugs and alcohol is referring people and trying to get them assistance. We need that person's we need that person to agree to get help though, and that's where we get a bit stuck. So we work very closely with these other people. We're not experts. We're experts at locking people up, basically. So, we really rely on these other people to assist us in getting people help. So that's sort of where I'm at. Just the two messages I wanted to leave you with are that alcohol is by far the biggest problem we have in the community, and certainly in our local community. And the other message I want to get out is this is not a policing problem. It's a community problem and a health problem. And that's why we're trying to work hard with service providers to get people off alcohol and other drugs dependence. Thank you.
We now invite Marcus Williams up to the mic, and Marcus is going to speak to us from Victoria Legal Aid. Thank you.
So it's sometimes the case that after the police comes the lawyers, and whilst Brad and his team are, or maybe experts at locking people up, I think that I have a fair degree of I suppose involvement in locking people up as well, but wouldn't suggest that that's really the answer that we need to come at in relation to drug use. I'm going to talk to you a little bit about Victoria Legal Aid, and I'm going to talk to you a little bit about the way the courts operate and how courts deal with offending in the criminal sphere. Victoria Legal Aid is the largest legal service provider in Victoria. It has a network of offices throughout rural and regional Victoria, and we provide a whole range of services to people across a vast number of different types of legal issues. So we touch on crime and family law, and they're probably the services that we're best known for, but we also touch on issues such as social security law, we touch on discrimination, civil law, and a whole range of other issues that people find themselves in, and they come to us for assistance. So the office I work for is based in Bendigo. We have 8 lawyers. 2 of those are specialist family lawyers. We're shortly to get a mental health specialist. We also have child support lawyer and a social security lawyer that come up to the office, and we have outreach services at the major towns throughout Loddon, Campaspe region, and we also attend at the 3 prisons that are in the boundaries of the area that we work with. And we provide advice and a range of other services. So referrals, lots of people come to us and they don't know if they've got an issue, a legal issue or otherwise, and we try and point them in the right direction if we're able to do that, and it's not something that we can directly assist them with. Legal information, advice, casework, we manage people's legal problems and run files for them, and we provide court representation for people. And just to give you a little bit of a sense of what that looks like, the staff at the office in Bendigo appeared in about 4,000 court hearings last financial year. So we spend a lot of time in court, and that's obviously not only in relation to criminal matters, but in relation to family issues and a range of other things. We provide duty lawyer services, and in Bendigo, that's a service that's shared with the private practitioners. So staff from my office attend court and provide duty lawyer services, which are essentially to assist people who come to court on any given day without a lawyer. And it's also provided by the private practice. So we do that in tandem, and Legal Aid effectively pay for those services. And legal aid is available to people not only through legal aid officers, but also through a range of private practitioners who undertake that work. So again, it's sort of like a subcontracting arrangement. If you've got a preferred solicitor that you want to attend, then you can go and attend at that solicitor's office. They can apply for legal aid for you, and as long as you fit into the guidelines of legal aid, then legal aid will pay that solicitor to be your lawyer in relation to that matter. Legal Aid does have guidelines, and you may have seen recently there's been quite a bit of talk in the media about the amount of funding that Legal Aid has to address everybody's issues, and that's been an increasing concern for Legal Aid. There have been growing numbers of matters, particularly in the child protection sphere and also in the family violence sphere, that have been a drain on Legal Aid resources, and we're hoping that that may change into the future. But that's why we have those guidelines, and that's why we can provide people with a range of services, but the nature and extent of those services may vary given those guidelines. We run a legal help line, which is a 1300 number, and it's a good opportunity or way for people to at least have a discussion with someone about whether they've got a particular legal issue and how to take that further. We also have a website which has extensive material on it and publications, and there's some publications over there that you might want to have a look at and take with you. All right, so drugs and legal issues and where we're seeing them. So we're not only seeing people who are being charged by the police in relation to drug issues, as both Peter and Brad have indicated. The drug issues are being seen in a range of legal issues, and there's an intersection between those, and most likely in the areas of child protection, in crime, in family and relationship breakdown, and in family violence. And so that's what we're seeing, is that people who are having these sorts of problems are also, not all of them obviously, but are or may be involved with either illicit drugs or alcohol. So what are the drugs that we see in the context of legal issues? And again, I'll harp on what's already been said. Alcohol is the primary drug and the primary issue in terms of legal issues and a coupling of the two. There is simply no doubt about that, and I think either Peter or Brad indicated that there's a lot of daylight between the next, and that is certainly our experience. The other ones we see at various at times. Certainly, cannabis is not probably so directly related to criminal offending, other than people who are being charged with possession, cultivation, or indeed trafficking of it. And the other drugs that we've seen are certainly involved in issues that people present with, but may not necessarily be directly involved with their criminal offending. There's certainly been a big increase in relation to ice use, and it's certainly a significant concern as we see it in terms of offending. And what we see anecdotally is that whilst there's not a lot of people who are getting in trouble using ice and offending, those that are doing a lot of offending. And I don't know if that's Brad's experience, but certainly alcohol is probably more associated with street violence or with family violence in the home. Ice is generally associated with either violence in terms of armed robberies, and I know that particularly in this area that has increased significantly, and also in relation to violence-related matters as well. So it's certainly a concern, but from our perspective, not the primary concern in terms of offending and a connection with offending. And I should just say briefly that I think Peter was right, that the drug of choices do change over a period of time. I worked in Footscray for 11 years through the 90s, and certainly there, heroin and heroin overdoses was a major issue for that community, and we seem to have now moved on from that, and we need to be looking at ice and ways as a community to address that. So we go to court, we're perhaps charged with a criminal offence in relation to drug use or possession or sale or whatever it might be. These are the principles that the court will look at in terms of sending a message and ultimately sentencing people in respect of their offences. And they're fairly self-evident. There's a punishment aspect, a punitive element to sentencing. There's specific and general deterrence, which is essentially specific is in relation to the individual, to deter the individual from offending into the future, and the general deterrence is in relation to a message to the broader community. Rehabilitation is a big aspect, and it's a big aspect of our advocacy, obviously. We want that to be the focus of the courts, and it's not always able to be. Denunciation and protection of the community seem to be growing in terms of the court's response, and Brad again touched on an issue about the numbers of prisoners that are currently in the system and the numbers of people that are currently on remand. And there has been certainly a lot of media of late in relation to, well, are we really tough enough in terms of sentencing, and are we letting people get away with what they shouldn't get away with in terms of walking away from courts? Certainly it's my view that if you can rehabilitate somebody, then in turn you therefore protect the community, because if you can rehabilitate them and stop them from offending in the future, then there is the protection of the community. Certainly there are people, and it's demanded that people get locked up, and that's what happens, but by and large those people at the end of the day are again released into the community, and then they need to be in a position where they're in a better place and are not going to offend into the future. So they're the principles of the sentencing. The outcomes, and Brad touched on some of those outcomes, the police take a very proactive approach at the start, particularly for offenders who haven't been in trouble much before, and involve themselves with police cautions and various referrals to keep them out of the criminal justice system. When we get to court, there are a range of sentencing options, and diversion is one of those. Again, it's an attempt to keep people out of the system and to address whatever issues that they have that underlie the problems that have given rise to the offending. And thereafter you'll see graduated response by the court in terms of punishment, in terms of punitive aspects of sentencing. I just want to touch briefly on the community corrections order, because this is primarily the court's response to rehabilitation, and a community corrections order allows for a connection to a whole range of supports within the community, again, with a view to trying to keep people out of the criminal justice system. So that's a very brief summary, and perhaps as we go through, you might have some questions about the specifics moreover. Thanks.
Good evening. My name's Lisa Walklett. I'm the Manager of Drug and Alcohol Services at Bendigo Community Health Services and have worked there for 15 years. We're very lucky with our drug and alcohol services that we're actually a part of a wider organisation as a community health, which takes in sort of wider aspects of a person's health when they come and seek service with us. The majority of our drug and alcohol services are, we're very lucky to have sort of quite a huge range of services that people seeking help can get some help from. We have a drug and alcohol adult residential withdrawal services called Nova House in Bendigo. It's a 5-bed unit that caters for people that are 21 or over, and probably our average ages would be sort of in their 30s, but we've had clients up in their 70s that have come into our service, as well as the 21-year-olds or 22-year-olds. Sorry. So it's quite a diverse range of clients that we come through. Still, the majority of detoxes would be alcohol and cannabis. So that's our detox unit. We have some counselling services, a youth counselling service up to 25, and adult counselling services, which caters for families as well as the individual. We have a number of support and outreach services available, with which is attached to some sort of a supported accommodation, post-withdrawal linkage support. So for the people that come through Nova, they do get aligned with a post-withdrawal linkage worker that then will work with them and link them into other services that they may need, such as GPs or work placement organisations, or even just negotiating Centrelink or other services that they may need. Also, as a part of our services, we have a number of groups, such as our collaborative therapy group, which assists clients. It's a group situation for clients with a dual diagnosis, so maximising or managing their mental health services or mental health issues, as well as their drug and alcohol substance use issues. We have a life skills program, and that's just looking at a lot of everyday life skills that a lot of our clients that with chaotic lives or chaotic substance use, it just helps to sort of bring back the life skills that a lot of people have sort of may have missed out on. So looking at strategies to keep them drug free a lot of the time, but also looking at nutrition, sleep, and that healthy lifestyle. We have a lovely pharmacotherapy clinic, so looking at your opiate replacement therapy. We probably have about 150 clients will come through there in Bendigo. A rural withdrawal service or a home-based withdrawal service, so one of my nurses will go out to the home or as an outpatient setting and see clients and help support them within a home-based sort of setting for a drug and alcohol withdrawal. The majority of our clients are self-referred. We do have a number of people that are on court ordered that will come through the door, but for counselling or for withdrawal. But the majority would be self-referral. We get a lot of referrals from general practitioners and work quite closely, especially within the home-based service, around drug and alcohol issues. We have an intake service, so our intake is available, Monday to Friday, 9 till 4, and there's a brochure over on the table there which actually lists in more details, all the services that we do have.
Thank you. We're now going to move on to hear from each of those other panel members here, and as they're representing the key service providers of alcohol and drug services across the city of Greater Bendigo. After this, we'll read a scenario and ask the panel to talk about how their particular services would respond to different parts of that. So as you go through, it's probably just worth trying to hold in mind the service type that we're speaking of. We'll ask each of the panel members to introduce themselves as they go down, and we would like to kick off with Kerry Donaldson, who is the manager of YSAS's Youth Alcohol and Drug Services in Bendigo. Thanks. Yes, we have to have the mic.
Hi, thanks everybody for coming out tonight. It's good to see so many people here. As Kim said, my name's Kerry and I manage a drug treatment program for young people in Bendigo. We are called YSAS and Peter is my boss, which is a very important thing to remember. I've been a manager at that service for 11 years, so similarly when I first started the drug use culture, the drug use culture was fairly much predominant around the heroin. YSAS as a whole is a statewide service. We offer a range of services to young people who are experiencing difficulties and problems with their drug use. They include youth outreach, home-based withdrawal. We have 3 residential withdrawal programs, one in Geelong, one in Fitzroy, one in Glen Iris. We have a residential rehabilitation program called Birribee in Eltham. We also have a range of day programs, primary health programs and outreach programs which I run. There's 2 regional programs, one in Bendigo and one in Morwell. The rest are sort of centred around Melbourne. In Bendigo we have 2 programs predominantly. Is a youth outreach program and a home-based withdrawal program, and we cater for people from the age of 12 up to 22. So if anybody is experiencing problematic substance use issues and wants some support, they can ring us. We're free, we don't have a waiting list, and we like to be responsive. So that's YSAS. We have a YSAS line that people can use, and we have a website that people can get support from too, which I'll leave details for at a later date. So that's YSAS.
Hi, my name's Carl Sayes and I'm the manager from Salvation Army, Alcohol and Other Drug Service. We're a residential service. So we were based in Kilmore between year 2000 and 2009, and we were burnt down actually in the bushfires in 2009. So Bendigo Salvation Army we had a counselling service plus a day program and a supported accommodation program. So in 2010 we came back up here because we had some units up here, and then developed our residential program, which was based from Kilmore. So we've been going for basically full time now, nearly 3 years. And it's interesting, same sort of thing. I've been working rehabs now for 12 years and managing for 10. I did have a year off. And same when we burnt down. And the same thing is interesting in 1999, 2000, 2001. The main drug was around alcohol, cannabis and heroin. And over the last 12 months, we've seen a massive increase. And we're just talking about it now, how we're trying to change our program around for the use of ice. And the same sort of thing is that we've seen our clients come through the court system. We're basically, between the last 7 to 8 years up until probably 12 months ago, our percentages were about 25 to 30%. Well, our last stats, I won't give it away, but our first quarter for this quarter was 52% were forensic clients coming through, and their principal drug was ice. So we have got a main problem, not just in Bendigo, but in the whole community, and what do we do about it? We run a program which is an intensive program for young people between the ages of 18 to 30. So it's for 6 weeks. And people say, how do you get someone to recover in 6 weeks? Well, it's not about that. It's about setting them some goals and some plans. We run programs, we do intensive programs. We run about 12 groups a week. But also we have some fun there as well. We do some art therapy, music therapy, visual art. We do a lot of woodwork once a week. We do recreation activities, which includes tennis, golf, swimming, canoeing. Also, so we're trying to find some spark and some fun back in young person's life again. We also help them seek, like if anyone refers into our service and they've been working with them for 1 or 2 or 3 or 4 years, they can still be working with that client once they're in our program as well. We won't stop that at all. We're there to support them while they're in our program and then follow up post-support when they leave our program and support them that way. So Salvation Army runs so many different programs through Victoria, but we're talking about Bendigo and Loddon, so we'll just talk about our program in Bendigo. So we're a 16-bed unit, and it's great and fantastic to be, I think, the last forum and this forum and talking to people through the region. It's exciting that we're trying to get, as a community, get together and educate people around alcohol and other drug use and doing something about it. So, like Daniel just said, I'm pleased to be part of that, and thanks a lot.
So my name's Daniel. I'm the Drug and Alcohol Care Coordinator for the Bendigo Hospital Emergency Department. My position has been in place since July of this year. It's a relatively new position. It's a brother or sister position, I suppose, to a bunch of other positions around the state. The Department of Health have funded 21 different hospitals around the state, 15 metro hospitals and 6 regional hospitals for these type of positions. Every hospital is doing it sort of slightly differently though. Essentially what my position is anyone who comes through the Bendigo Hospital Emergency Department that has an identified drug and alcohol issue, I can see and provide service to. As the care coordinator, basically my role is to provide assessment to individuals. Of course people have to be consenting, so the staff in the emergency try to encourage everyone that comes through that we identify drug and alcohol issues in to speak to me, but if people decide they don't want to, we can't sort of force them on people. Basically what I'll do is I'll do an assessment, I'll talk to them within the time they're in hospital about their drug and alcohol issues. I'll then talk to them about where they're at with those. Sometimes that'll involve just providing them with some information about the drugs or the alcohol they use, potential risks, information around how to minimise harm, a whole heap of educational type interventions there. If people are interested in accessing services, I'll talk to them about what services are available in the local area, how to access them, and that will include, I suppose, the Bendigo Hospital is the biggest hospital in our region, so it services the whole Loddon, Mallee, Southern Campaspe region. I think I got that right. Big region anyway. Services the whole region, so we'll get people that will sometimes come from other sort of small regional hospitals to Bendigo, so we can link them into services in their local area. So if someone wants to come from, say, Kerrang, for example, they could still see me and I could still help them to link in with the services local to them. Now, majority of drug and alcohol services are self-referral services, so people can just contact themselves and refer, but I'm also happy to provide assistance with referrals and sort of facilitate that referral. That's part of my role. Other things that included in my role are sort of bigger things across the hospital. Primarily I do service the emergency department, but if we get people that come through emergency department that will end up in other units like our medical unit, our surgical unit, or even our acute psychiatric unit, I can provide follow-up there. There's also a lot of stuff that I'm doing with staff in the emergency department around training so that we can better identify drug and alcohol issues in patients that come through. There's no typical drug user or typical alcohol user. If you sort of try to look at a particular person and go, well, that person's going to use drugs and alcohol, but then this person isn't, you're going to miss a whole heap of people that do potentially have issues. So we're trying to, part of my role is to try and introduce processes to ask the questions of everyone that comes through the emergency department. The other part of my position, I suppose, is to get out here in the community and do things like this, also build the relationships with the other services around the area, so that we can sort of facilitate those people accessing those services when they best need them.
Hi, I'm Jenny and I'm the Program Manager for Headspace in Bendigo. We've been in Bendigo for 2.5 years. And Headspace is a national Commonwealth funded service. I'm nervous. And we early intervention, health promotion, we see people with mild to moderate issues. And our main focus is mental health. However, we work with people with any kind of problem. They can come through our door with any issue. We have doctors, nurses, social workers, psychologists, you name it, we've got them. And it's free and it's a very little waiting list. And we have a dual diagnosis clinician that's funded by St John of God. So, yeah, drug and alcohol, mental health, sexual health, sexual identity, you name it. You can come in with a sore thumb if you want to. Anybody can come to Headspace, and they do. We work with people from 12 to 25, and nobody needs a referral. Kids can just come in. They can be referred by doctors, or they can just rock up. Parents can refer. Families can be seen with the kids or without the kids, but we always aim to work with the family, but if the child doesn't want the family involved, we won't make them do that. So we do a lot of our work, probably at least half of our work is around dual diagnosis. So it's usually a drug and alcohol or alcohol problem with anxiety or depression or some attachment or trauma issue that's happened in their life. So I think that's it. Thank you.
So I'll read the scenario which we will put to the panel and Peter will operate as agent provocateur and ask the hard questions. So, and this person is this is a scenario that's not uncommon in our services. So a 20-year-old male, Josh, and by the way, you would have heard already, age is a thing in terms of our services, and it's not always neat. It's just so it can be messy in terms of the ages. A 20-year-old male, Josh, whose name is Josh, has been using drugs and alcohol for the past 9 months. His family have recently found out about his drug use when he lost his job as a second-year apprentice builder. They are concerned about his future, about his agitation towards his family, and also about his apathy regarding his drug and alcohol use. They call YSAS to make an appointment for Josh to see an AOD youth outreach worker. YSAS and Peter.
So what we're trying to get here is a sense of how...
you'll need the mic, Pete.
Oh, they'll hear me. Seriously.
The
The TV, that's right. It's a shame my parents are both dead. They'd love to see me on TV. But anyway. Okay. So Josh is referred to YSAS and he turns up to YSAS. So Kerry, what does YSAS do when we get the referral for Josh? Into the microphone, Kerry.
Yes, you just watch your own microphone and I'll watch mine. So it depends. If the family makes the referral, we'll talk to the family about have they spoken to Josh. Sometimes people are wanting to make the referral for Josh on his behalf and he's not that keen. So we might talk to the family about a way to introduce the conversation to Josh to highlight some of the benefits of coming to talk to somebody about YSAS. So they would talk to Josh and Josh say, okay, because if he doesn't go, they might throw him out. Okay, so they come to some sort of agreement and they all would possibly come into the service. They would meet with an alcohol. I would hopefully want to talk to Josh beforehand. So say, hey Josh, this is who we are. You know, what's a time that would suit you? And we'd make an appointment. He would come into the service with or without his family, but Josh has come in with his family. And so we would sit down with the mother and father or the mother or whatever person comes with Josh and just really try and work out what the issues are and really work with Josh from what his perspective is. Josh often would be reluctant to talk openly with his family, and so it might be that we have part of the session of assessment with the family and then ask the family to maybe have some time with Josh alone. We would be looking for doing a risk analysis or assessment of Josh to see if he's at harm to himself or other people. We'll be looking around, doing a screening around his mental health. We would be trying to ascertain why Josh uses drugs, and does Josh see he has a problem with drugs. Josh generally wouldn't see he would have a problem with drugs. In this first presentation, 9 months use, he would be seeing that other people are really trying to over-control his life, and that it's just an unfortunate series of events, not necessarily his drug use that has forced him to be in this situation. We would offer Josh another appointment time. Often assessments might take over two times, and Josh may say yes and not turn up, or Josh would just say, no, I'm not interested. And then I'd offer the parents some support, not necessarily directly through YSAS, but link them to their other support networks, community health, centre care, their GP for a mental health plan if they could get some assistance that way.
Okay. So how common is it for young people to come in with their parents into a service?
Into YSAS it's less common. We at YSAS generally or historically have worked with young people whose family is quite fragmented. A lot of the young people that we work with come from a whole range of disadvantage, including trauma and poverty, disconnection from school. So often their families aren't invested in their child's recovery, and then there's other children that don't want their parents to know about their involvement at YSAS, so they would seek treatment independently or with friends.
Okay,
Yeah.
great. So we have Josh. Josh meets Kerry, the family come in, the family are really distressed, but at the end of the day, Josh says, this is your problem, it ain't my problem. I don't know what all the fuss is about. So Josh disappears, right? But he doesn't disappear for long. So Josh does not think he has a problem, but at 21 years of age, police attend a vehicle accident where Josh is involved as the driver. Josh has sustained minor injuries. They take a drug and alcohol screen test, and it shows that Josh has been under the influence of substances. Josh is searched and found to have possession of a small plastic packet which contains an illicit substance. So, what happens with the police? You found the drugs, what goes on from now?
Certainly from the accident point of view, he would be interviewed about driving under the influence if those tests return positive, and as your scenario says it did. He would also be interviewed about possession of the drug. What happened after the interview and how we finish that off would depend on what the drug was, what his history was, as to whether he gets charged or cautioned or diverted, or whether in fact the drug is in fact a drug of dependence and a legal drug. So they're the sort of options that we would look at, and then we would also use what we call a support link, which is one central number we call, and we would refer him into, if he gave us his agreement, we would refer him on to support services to help him.
Okay, great. So Josh is being looked after by the police. The process is going to take its course in terms of the legal application, but as you've heard from the police, they're also concerned about his welfare. So police are really concerned about Josh's mental health state, and they take him to A&E. And who do they meet at A&E? But they meet, that's right, they meet our friendly drug and alcohol nurse assessor. And he kindly assesses Josh. So at the presentation at A&E, you're called in. What goes on from your point of view from there for Josh?
All right. I suppose firstly, who gets involved with Josh would depend on what concerns the police actually had. If the police are taking him to the emergency department and they've got concerns about his mental health, they might actually use Section 10 of the Mental Health Act, as Brad talked about earlier. So when Josh comes to the emergency department, he'll be seen by a clinician from the mental health team in the first instance. They'll have to go through their processes of assessing Josh. They might get a doctor from the mental health service to assess him. There'll be processes that will happen there. As far as the Drug and Alcohol Care Coordinator, my role is concerned, depending on what time of day it is and that sort of stuff. If it's during my working hours and I'm a single position, unfortunately, I could be there 24 hours a day, but they
We
won't.
expect you would be.
Yeah. They're not going to pay me enough to be on call, so yeah. So if it's in my business hours, I liaise very closely with mental health services and the team up there. I actually have previously worked in mental health services for 15 years, so I've got very good relationships there. I would assess Josh. This is assuming his consent. So again, if it's within my business hours, I'm quite happy to go up and introduce myself to people that come in like Josh, to introduce what my role is, to offer an assessment. If Josh tells me where to go, I've got very thick skin, it's not going to hurt my feelings. I sort of leave him to it. I might give him some information about my position if he'd like to contact later on. If it's after hours, what I encourage the staff to do is to ask the patient for their consent to refer to me. If the patient consents, they'll make a referral and then I can provide some telephone follow-up later on. Sometimes that will be when the person's been discharged. Sometimes the person will actually require hospitalisation. In Josh's case, it might be that he requires a stay in the acute psychiatric inpatient unit. If he sustains some injuries, he might need to receive some treatment, like in the medical unit or something like that. In that case, I can actually follow him up in hospital. As I talked about before, when I talked about my role, I would do an assessment at where he's at with his substance use, what he wants to do about it, and then I'd link him into one of the good services here. If he's had a involvement with YSAS in the past, I would sort of talk about his relationship with YSAS. I would probably try and encourage him to reconnect with YSAS. However, if that's not what he wants to do, I would talk about the other services that would be available for someone of his age and sort of talk about where we could go from there. The sort of services that we might look at linking him into is we might talk about some youth-specific stuff, so something from Headspace, particularly if there's mental health issues, if he hasn't enjoyed the experience he's had with YSAS, and that may not be anything to do with YSAS at all. One thing that I really have to explain to the staff of the emergency department is people need to consent for referral to me. If I'm going to be chasing someone up over the phone at home, I don't want to be ringing up, getting mum and dad at home, and mum and dad have no idea that Josh has been involved in a car accident, he's had an admission to the hospital, that sort of stuff. I don't want to be leaving messages on someone's phone for, like, say, Josh's girlfriend to hear, because what actually happens there is people then have a experience with me, who, even though I work from the hospital, I'm representing drug and alcohol services, and it's a negative experience for them. Likewise with YSAS and with other services, if people are forced into that service by family and that sort of stuff, and they're not ready to address their drug and alcohol issues, often what their view can be is, well, I've already talked to that service and they were no help. But in actual fact, the person didn't want to make any change. They didn't think there was an issue. So we need to make sure that we actually work with the person's wishes. And just because a person doesn't want to address their issues at that particular time doesn't mean we just do nothing at all. We will use a number of different interventions to talk to them about their substance use, potential issues that can cause potential risks for their health. And by giving that information, what hopefully will happen over time is a person will come to a realisation that, all right, maybe these are issues I need to deal with. Maybe I do need some help to address those.
That's great. So that's fantastic. So a lot of work's gone at the hospital. Josh is pretty vulnerable at the hospital because he's hurt, he's had an encounter with the police, he's probably thinking about what's the hell's going to happen to me next. But as he gets into more recovery mode and he's accepted a few referrals, we've detected through our assessment that maybe there's some anxiety and depression there. So we call Headspace. So what would Headspace offer Josh? Yes, you do. And you probably have to pull the microphone down.
Taller than Daniel. Okay. So Headspace, we have a lot of Joshes.
Yep.
So if Josh comes to Headspace or he rings Headspace, we would make a time for him to come up and meet with our intake access worker, and he would get a comprehensive assessment.
Is that painful?
No,
'Cause it
no, it
sounds
doesn't
painful.
hurt. No, it doesn't hurt. It's just a question.
How many people here would like to have a comprehensive assessment? No, it doesn't sound good,
Oh,
does it?
okay. All right. So we
Okay.
talked to Josh about what are his issues, and we look at all the different things like his home environment, his health status, his drug and alcohol issues, his sleep, his mood, all those sorts of things in a general way, not
So
painful.
I'm Josh's mum,
Yep.
right?
Yep.
And I'm thinking...
Did you
everyone-
come with Josh?
No, no,
I
no.
can't talk to you
No,
then.
no.
Sorry.
That's right. So that's my problem.
Yeah.
I didn't come with Josh.
No.
But I love Josh.
Yeah, of course
right?
you do. You
And
can
my
talk
heart-
to me
my
about
heart's
Josh.
breaking, and I talk to you, so I can't talk to you because you didn't come with Josh. And
No, no,
Josh-
you can talk to me,
Can
but
we?
I can't talk to you
Oh, okay.
unless Josh says it's okay to tell
Okay.
mum.
So here's a point, eh? One of the things the community often gets frustrated about is the issue of consent. And it isn't that services don't want to talk, it's that we're not allowed to talk by law. So that's one thing that we really need to understand. Consent is a big issue, and I know the police battle with this all the time. So consent is a fickle beast. At the one hand, it can be very helpful. On the other hand, it can often stand in the way of great communication. So families often feel excluded
Yep.
because of the issue of consent when that isn't the intent of the
Yep.
service. We see it all the time. So that,
Yep.
thanks for that. So
But we would always encourage, as we continue to work with Josh, to involve his family
Great point.
and get them to come in
Yeah.
and be part of
so
the
you're not
support.
anti-family.
No way.
Right.
But we would also be looking at what Josh sees as his issues, not necessarily be honing in that it's a drug and alcohol. We will work with what he wants to work with until he's ready to tell us that his issues are related to drug and alcohol.
Okay.
Yeah.
You can sit. Okay, so Josh has been referred, but surprisingly enough, Josh doesn't want to go. So he says, YSAS, they're useless. Never met with them, but they're useless, right? Not interested. You know, what do I need to talk to someone about? I don't want a comprehensive assessment because that sounds painful, right? That just sounds really terrible. So he's not interested. So this is what happens to Josh. Josh's family, who are the constant in all of this, they live with him, they love him, they care for him. He's in really deep trouble because of the drug driving and the accident that he had and the possession that he was found with illicit substances. So Josh's family make a referral to legal aid. So let's talk about what legal aid would do when Josh turns up.
Well, again, we would hope that Josh turned up and that we were talking to Josh, because at the end of the day it's Josh's problem, and primarily it's a legal problem, and we need to assist Josh to deal with that legal problem. We're happy to talk to Josh's family, again, if Josh's family are interested and Josh is happy for us to do that. And we'd probably point out to Josh that there might be some significant benefits to doing that, to being able to go to court eventually and show the court that there's some strong family support, and also that perhaps Josh is undergoing a treatment process that is trying to address the issues that might underlie his offending. So we'd suggest to Josh that it would probably look pretty good in court if he was doing the right thing and addressing the underlying issue. And we don't do that just because it looks good in court. We do that because ultimately it does address the underlying issue. So apart from analysing Josh's case, working out whether he's going to plead guilty or not guilty, they're the sorts of things that we talk to him about.
Okay, so Josh goes to court. And in court, he receives a community-based sentence with a condition that he attends an AOD treatment. So up until this point in time, Josh has been able to say, I don't have a problem, it's your problem. I'm not interested in talking to anyone about my drug and alcohol. Now a court, a judge, a magistrate has said, mate, you've got a problem with drug and alcohol, you get it addressed or we're going to lock you up. So no longer does he have a choice. And he's referred to Bendigo Community Health. And he's referred to Lisa's team and Lisa's program. So what do you do, Lisa? He can't tell you to go away. He's got to turn up.
He does have to turn up, but he still probably, or he may not turn up, and there's consequences to that as well. However, if he does turn up, we could provide some counselling, youth counselling services for him. We would also, you know, the order may also be for, say, a withdrawal episode as well. So we would actually assess him as well, I'm afraid. But for his withdrawal needs and looking at, again, a comprehensive withdrawal around his health, mental health, and psychosocial response. So looking at, you know, what legal issues he has, what housing support, what education, you know, a lot of the issues that have influenced his life up to that point. Looking at his medical and assessing him for what his withdrawal needs are. So whether it's a residential withdrawal, whether it's a home-based withdrawal, or whether he's, you know, medically or mental health stable enough to actually have that treatment here in Bendigo, or whether we have to actually assess him and refer him down and facilitate that referral down to Melbourne to another, you know, a Melbourne more medical supported detox. But I just want to make a point too, that we would also provide some support for the family as well. We've got, you know, our counsellors would be able to see the family members and provide support for them, and maybe also support them with some other local services such as family drug support here in Bendigo, which there is a support group here.
Fantastic.
Yep.
Okay, so Josh has to attend. He does attend. And surprise, surprise, Josh identifies that he has a problem. He goes to Nova House. He does his withdrawal. While he's in Nova House, he says, I am really worried about going back into the community and just undoing all the good work that I've done at Nova House. I've got myself clean and straight. I want to stay that way. Where can I go? We go to the Salvos and we look at the Bridge program. So what does the Bridge program do with Josh?
Yep, so Josh would come straight from us from Nova House into our program. Lots of Joshes in our program. And Josh would be referred to one of our beautiful workers over there in John. So John would work a beautiful little case plan out for him over 6 weeks, and that will include in addressing his drug issues, looking at his life issues. Also, from January next year, we're going to have also a program which includes families. So Josh's family would be absolutely able to come through our program. Also, we'll be looking at putting some strategies into Josh, teaching him some drug education around for Josh as well. And the same story though, listening to that poor Josh, he went through the whole ringer there, didn't he, really? But we see this all the time. But at the start, even if he's mandated to come to then a program like us, we see changes. It doesn't matter if they do get mandated and they come to our program and they first come in and go, oh, we really don't want to be here, but we have to be here because we keep us out of jail. I know it's only a 6-week program, but by the time they leave out of 5 or 6 weeks, we see massive changes in them, and they actually see changes in themselves. And and I won't go into it now, but we just saw someone today and the other day, and it went through our program 2 years ago, and they were mandated to come to our program, and one of them is still clean today. So fantastic results. So hopefully Josh wouldn't have to go through the ringer like that, but it does happen. But also we will then, unfunded, we then do post support when they leave. And as part of our, even if we linked them back into Bendigo Community Health, or they went back to White, they sort of bad Weissas, they went back to Weissas, that would have been great. Yeah, we would have sent them back to Weissas, and we would have actually then also followed up by weekly, by fortnightly, by monthly, by 3 monthly, by 6 monthly, and see how they're going. And like I said, it is an unfunded position, but we would do that, and we always do that with our clients. And also, we would then, if they went to Bendigo Community Health, we would follow up and find out how Josh is going. So they would be linked back into that service with a full, I think if anyone's seen our discharge summary, it's about 4 pages long. So that's what we'll do there.
Thanks, Carl.
No worries.
Great. So thanks everybody. So what you're seeing is, let's say it's not an ideal role of how someone would get, or a right ideal model about how people get help and treatment. But what it does reflect is that often when you're dealing with drug and alcohol problems, you are dealing with an imperfect set of circumstances that doesn't follow, you do A, then you do B, then you do C, and you end up with D. And for those of you that have had experience in your personal lives with family members, or maybe your own journey, you would know that there's many times where it's 1 step forward, half a step back, 2 steps forwards, 2 steps back. These things take time. These things take time to resolve. So thanks, panel. And I think now we're going to hand over to Kim, and she's going to conduct the Q&A.
Well, that we are, although I was going to... Sorry. I think I did. Yeah, I did. Thank you, and I've just asked for some assistance, I reckon, in a tick around the roving mic, although first we do have a couple of questions that have come through that you've put forward already, and I guess one of them I'll just take microphone holder licence, and that'd be good because it might be some of it to our panel and some of them out here when we ask people for it. One though was said it's we really need a one-stop place, a central place that we can go and get help. There are so many places that are related to drug issues that it's overwhelming. Could this be possible? I'll very quickly just say it's such a timely question, and I'll ask others if they want to comment, in that alcohol and drug services are being recommissioned, and one of the things that, and again here in Bendigo, we're taking a very collaborative approach, and in fact many of the people on the panel are working together to develop up a bid that will go across our region. One of the things that is currently a real struggle for us is how do we get one central intake system whilst not taking away place-based responses so that local areas across our region can respond. It's a debate, but there is part of that recommission is that statewide there'll be some centralisation, and then regionally there needs to be some centralisation in terms of intake, but then there's still capacity to feed out. Having said that, the AOD services are being recommissioned in stages, so it's not going to address some of the age issues. Like they'll go in different stages, and I might ask whether anyone else wants to comment. And I know we've also got the chair of the VADA board here with us as well, who's helped with some of the recommissioning. But just in a nutshell, I think it's to say we're working on it, but it's not simple. It's trying to deal with what's going to work, while having it centralised but not depersonalising it so much that it ends up a bureaucratic nightmare as well. Did anyone want to say anything more to that before I ask the next question? No? Okay. Again, if we haven't answered your question, feel free to get hold of us too, but that's it. The other question, while we're just to buy you a bit of time in case you're getting ready to put your hand up, I've already passed on to Brad because it seemed like it was most relevant to him. And it was really about why don't we act on those places where we know there are drugs? And Brad might want to read that question out if I've not captured it as well as I should have.
Yeah, thanks, Kim. The question, as it's written, is why are we not doing more to stop the known availability of within such places as, and it's named 2 places. I don't know whether you want me to name those places or not. And, look, from a policing perspective, we get a lot of information, intelligence about submitted every day. We get dozens of pieces of information sent into us from members of the community, and most of that is around drugs, illicit drug use. All I can say is I don't want to talk on specific cases or how much intel we hold or what we do with it, but some of the options open to us are we get that much information, we're not going to act on every piece of information we get. Sometimes if we get 1 or 2 bits of information and it is an issue we can address directly with a premises or a particular building, we may work with the operators of that building to pass that message across, as in, are you aware this is going on in your building? Generally they aren't. If the information we get is excessive information and it's a lot of information specific about drug dealing or drug offences, or it may even involve corruption by people who work in a particular building, one of the options open to us is to apply to a magistrate for a warrant, search warrant, under the Drugs Act. So that's probably the 2 areas we will work in. We will either act on a specific information to get a warrant, or we may choose to ignore the information and just file it away for future reference, or we may work with the operators of that venue to make them aware of the issues if we think that's the appropriate way to go. So they're probably the options we've got with that.
Thank you. Now I have some other questions that came in through the council's website, but I wonder if I'd like to first give anyone in the audience the opportunity to ask a question directly if you would like to. Those 2 that we've just asked had actually come from you tonight. But is there anyone that would like to ask a question or make a comment to the panel? Can I take up the back first? Thank you, and then the lady. and then you see.
Okay, I just wanted to make the comment from a parent perspective about what support's available for parents, and I was a little bit disappointed to hear that no one mentioned the Family Drug Support Group, which I didn't hear that. I'm sorry if I didn't, but it would have been great to have some representation from them, because I think they provide very necessary and invaluable support to parents who are also on a journey with their drug user. And you know, I'd like to say that you have to wait a long time sometimes for change, and parents need a lot of support while they're waiting for that to occur. So I'd really like to reinforce that fact.
Yeah, no, very good point. Yeah, Lisa did actually, Lisa noted that in fact they would be a service to which she would seek to try and refer the parent, but it's good to reinforce it, it's great. And Kerry's just reminded me that in fact we did invite them to participate. So they weren't able to join us. So, Peter, the lady with the striped shirt.
Hi, I'll just introduce myself. I'm one of the GPs down at BDAC. I'm quite new to Bendigo, so not many people know me. Just a comment about centralising processes to sort of reassure people. There are some risks with centralising things, because I work extensively with mental health, drug and alcohol, assault and family violence, etc., sexual health. So more a social medicine practitioner than anything else. And one of the biggest issues that we have, particularly working at BDAC, which is a co-op, is that when you centralise a process, some people don't want to attend because they see previous users that they used to hang out with that they don't want to be around anymore. They are sort of confronted with a lot of people that they don't want to associate with. So it's often good to have various places to go. I think the most important thing is the planning, is actually laying out, and you often have to do this more than once because people forget or get lost in the system, is having them have someone to go back to, like their drug and alcohol worker, to go, where do I go now? And be given options and choices, and this has to be done over and over and over again. I think it's completely fair for the police to be stating that they can't run around following every lead they have. It's frustrating for all of us, it's frustrating for families, for practitioners, and for some people who are users who are trying to get out of certain areas where they've given information and that can't be acted upon. We can only act on the within the confines of the law and what we're allowed to do, and it's heartbreaking for a lot of us. But it's just a matter of chipping away at what we can and supporting where we can. And making sure that everyone's questions are really answered and hearing what people are saying and what they're asking for.
Yeah, absolutely. And I think you've summarised very well some of the discussions we've been having about how do you get a balance between something centralised that gets equity across the region, because we're thinking if you live in Bendigo it's not so bad, but if you live in one of our smaller communities it's really hard to get to supports or even know where to go to. And I think your comments really captured some of the discussions we've been having about how do you get a balance, and almost that you've got to have two bits, haven't you? You've almost got to have, perhaps if you can swing it, something like an 1800 number or whatever, but also place-based where people can walk in and you will get a response and it's local. But we're not yet, we haven't cracked that nut yet, but certainly I think we've only got about 2.5 weeks to get it sorted, so we'll certainly try. But you're right, you've got to keep all of that in mind, or we throw the baby out with the bathwater while we're trying to fix it. Do we have other questions? I mean, as I said, I've got a couple more questions here, but up the back, please, Peter. Thank you.
Hi. Look, my question's very specific, and Peter only touched on the drug very, very sort of fleetingly before, and that's Xanax. And I'm interested to know if anyone on the panel knows, and it's a sort of two-part question, I guess, if anyone knows what the situation is regarding Xanax, as in this sort of 6 to 12 month period. I take it that some of the, or maybe even a vast majority of the people on it are going to come off it during that period. And the second part of the question is, basically my son was put onto Xanax 6 years ago for post-traumatic stress. 6 years of doctors prescribing this filthy damn drug and saying, yes, it's okay, stay on it, stay on it. 6 years. Now, at the end of that 6-year period, we were in the position where he was apprehensive about going into Nova House or going into detox simply for the impact that it might have on a court case that he had before the court to get more access with his children, a side point. But because he was apprehensive about going into Nova, we were in the position where we did it ourselves, and I hadn't realised how bloody dangerous it was to do that.
And I was just going to sneak over to ask if Lisa wanted to comment on that when you mentioned Nova, but is Lisa?
I think it's really important as a part of the, in a part in assessing the drug use is to finding out exactly what they're on. Xanax is a terrible drug to actually withdraw off, and it does take a lot of planning and actually a well-monitored response to see the reduction of it. And it often is over a long period of time, not just, and Peter touched on the concerns about just stopping it completely, any benzodiazepine stopping it completely, but certainly Xanax, due to the withdrawal syndrome that comes with it. Any Xanax withdrawal that we would sort of help facilitate, it's certainly a well-planned and monitored and reduced at a level where the person can cope with it.
Well, but sorry, I was just going to ask: is it more that we haven't given as much awareness to services other than Nova House, because it is we could have offered support around at-home withdrawal too. So I'm wondering whether part of it is also about you felt you had no option but to go it alone, and I'm just wondering whether we didn't. I'm wondering whether awareness is one of those things, like do we need to do a lot more work to say what else is available, because we could have supported that at-home withdrawal. Yeah, and that at least we'll have this comment too from a GP at BDAC, but it's also, I think, for the other services, it is also about us trying to support you more in terms of Nova's only one part of the services that agency offers, and maybe we need to work harder to make sure that those other options are understood, because that just sounds diabolic, and it didn't need to happen, and I'm really sorry that you didn't know about what else was offered, and we'll need to work on that a bit more. There's a comment here and a question here, so maybe just the comments quick.
I have extensive experience with Xanax.
Cool.
It's quickly being replaced now as sort of the party drug of choice by Seroquel, which doesn't really help us any. The biggest issue, I think, with general practitioners is that Xanax was exceptionally well marketed. The drug reps were very good at selling it. It was the answer to everything from a GP perspective. I don't prescribe Xanax except to people who have long-term low-dose effective benefit from Xanax, and really everything else has failed. So I tend to agree it's a devil of a drug, so I'm with you on that one. The unfortunate thing is most GPs that I come across, and they'll freely admit this, aren't really great at dealing with mental health issues and PTSD and things like that. There's a lack of comfort in dealing with it, and it's a really tough area to deal with. I know that a lot of the education systems for GPs are starting to really gear up towards mental health and educate GPs so they can feel a bit more in control about it. But it's about finding a GP that will actually know what they're doing with it and be able to deal with it. So I know I'm one of them, and there's a couple around there. But it's a really tough thing to deal with. Particularly Xanax, the withdrawal violence is huge.
Okay, so next question. It is, so it's about finding the right GP, but as you said, you tried 3, and I agree, there's not many. And the other bit is knowing we could have also assisted, but we've got some work to do. If you didn't know about that, we've got some work to do. Sorry, over to you.
I've lived in Bendigo since 1979, and there's been some big changes around as far as drug use goes. It's acknowledged here that alcohol is the major problem. And we have regular breastbeating in the local press about the terrible results of street violence on a regular basis, and you see some terrible programs on the television about permanent damage done to young people, usually in their 20s, usually young men. They're permanently damaged forever with head injury after hitting the concrete. We had, a couple of years ago, we had a sham conference here in the town hall. It was widely publicised by the local politicians and local officials about controlling and curfews on clubs that sell alcohol after a certain hour, and after a great deal of noise, the result was completely zero. Now, in a number of cities in Australia, notably Newcastle and Broken Hill, they have instituted curfews for clubs for certain hours and selling alcohol, and these curfews have worked. And the results are that trauma and violence on the streets and admissions to accident and emergency have decreased. It's regularly, if you listen to the ABC enough, you'll hear stuff about Newcastle and Broken Hill as just two examples where it has worked. And the community is behind it, and especially even more so after the results have come in after a few months. So my question is, all we've got is a $400,000 facility, sort of nighttime safety zone thing, which was put there at the public expense, $400,000 plus, I believe. So when is the City of Bendigo going to stop stuffing around and do something about putting curfews on sales of alcohol after a certain hour, so that our young people who are prone to take excessive amounts, you get a violent situation in the streets with trauma? When are we going to grasp this and do something about it? It's very simple. We just have to have the courage, and we're not doing it, and it's pathetic. This has come up so many times over the years, and we are not doing it. And we only have to look to these other places to see that it can be done.
Okay, we're going to make a couple of comments, and I'll ask if anybody from council wants to make comment. But I guess I would say, thank you for your proposal. What we had determined we wanted to do from tonight is not really lock in any particular solution. We wanted to share awareness. We wanted to try and make sure there was good information, and we did want to listen. We do know there are gaps, and we also are pretty keen that this is part of a process. This needs to be, and I think a number of the speakers have said it, I know Brad said it first, drug and alcohol and other drug use has to be a community effort if we're going to shift it, and that's consistent with what you're saying too. And we have to look at this in a multifactorial way. We have to look at how do we make sure there's a service response when someone is in strife or does have issues with substance abuse. And so we've got a number of services that I think do a really good job on that. Not a perfect job, as Peter said, and it's not that there aren't gaps, but we are learning, and we're starting to work together better as a result of this initiative to try and address them. So there's one bit is the service response. The other bit is really and truly, how do we then work as a community to try and reduce the number of people for whom alcohol or other drugs is the only way they think they're going to cope, the only way that they can solve that short-term pain that Peter's talking about, or the only way, and that ends up being a much longer term problem. Now, the issue of curfew is one really hard proposal that's come up. What we had decided, because again, those of us lot and council were pretty determined that we don't want this to be a sham. That, this is not, everyone's got better things to do with their time than just go through. We could achieve a bit just by good information, but this is about us as a community, City of Greater Bendigo, trying to actually do what we can from the ground up as well around making this a healthier community and giving both young and old better chances to have healthy lives. So we have a number of things that are happening. We have a commitment from council that the machinery of council will develop a report based on things that are coming out of this. So they'll report back to councillors around what's come up, and I can ask whether there's anything that we're able to say about that, but that's very early. That's just about them saying they want to make sure we capture the outcomes of this and make recommendations. We also have the Safe Community Forum, which had said they would be keen to take recommendations from the forum as things come out to look at, because it's one of the ways you can bring some of those proposals up and have them considered. There's also the crime prevention group, and I know we've got a rep here, and I might ask if anyone would like to speak to that, as well as then a range of other things such as a group that's come together across the city of Greater Bendigo called the First Quarter, which is looking at the 0 to 25s. But those, particularly the things with real teeth, like the Safe Community Forum, the Crime Prevention Group and a council report, is a mechanism through which to capture some of those proposals, and any of those would then have to do work to work out whether that's the best solution for this community or not. But my sense would be we're probably going to have to approach a lot of different things for us to really bite on this. Tim, did you want to say anything about the Crime Prevention Group?
And it is very much determined to, I guess, and in confirming what we're talking about tonight, it is really about a longer term strategy that addresses the issues around alcohol and drugs, particularly alcohol. I mean, we've focused in some senses on ice because it does impact in particular terms around that, serious crime. But alcohol has and will remain for a very long time, unless we do something about it, the key issue in our community.
Yep.
And so really only confirming what's been said tonight. It is a longer term strategy. It is a community issue, and it will need community involvement to fix it. Simple as that.
It will, and I guess too, thank you, and I guess too it's also picking up, like not taking away if we've got evidence of other places and things reducing it, but also we've got to marry in the comment that Brad made early too about a lot of what we see is actually happening in the home. So it's, it's got to be more than one strategy. I notice Brad's got the mic, so comment.
Yeah, just from my my normal role, I'm the licensing inspector for the Greater Bendigo area. Work very closely with the licensing fraternity and the council and the Victorian Commission for Gaming and Licensing Regulation. They're the regulatory body. Look, it's a really difficult issue, this one of your raise of curfews and that. Yes, I agree. If we limited licences to shut earlier, we would have less violence. There's no doubt about it. It takes, I don't think it's as easy done as let's just stop issuing licences as late as we can, because we've got to have the political will behind it first. I don't know that that's around yet. There are many licences across the state which are 24 hours, which is ridiculous. However, in Bendigo, we have very tight regulation on the licensing industry. And I must say that predominantly, as I spoke before, the majority of our alcohol issues are from people drinking alcohol at home. The pubs and clubs are very tightly regulated. There is very little trouble in them. Certainly it draws people into the centre of town, there's no doubt about that. But to lump that issue with the licensed premises who are running their businesses within the laws, I don't know that that's entirely fair. So, look, I think it's a complex issue. I don't think it's as easy as just shutting earlier, and putting curfews on people. So, but it is a really complex issue. I'll certainly talk about it within the committees that I sit on, which is the Community Safety Committee and the Liquor Accord. And I'm in regular contact with the licensing commissioners from the regulatory body. It's probably where I could leave that. I don't know.
Thanks, Brad. And I think it is about the capturing of the various ideas and then putting them through a process, isn't it? And seeing just what it is we think would have the most likelihood of making the difference, and it's likely to be more than one thing. Just before we wrap too, can I just ask if our reps from council need it? Did you want to say anything further, or did I misrepresent what you'd passed on? Are you happy that we leave it at that? Did you want to make any comments, Susie?
Thank you. Hello, I'm Susie Mansell from the City of Greater Bendigo. I think, Kim, you've covered it really well, and I think from our point of view, it will be really important we're here, we're listening today and trying to understand what some of the concerns are and gaps. And as Kim said, as council officers, follow up and report to council about the sorts of things that have come up this evening. And we'll be listening and looking to see what things we might be able to do in the future in our planning to address some of these community issues. So thank you.
Just terrific. And I know that council are taking very much a facilitative and enabling role, and indeed some of the solutions might mean that what we'll be asking them to do is help us all advocate, because it won't all be within their mandate.